afternoon, everyone. Uh, I would like to introduce Dr. Luigi Manfredi, who is a senior lecturer in the School of Medicine at the University of Dundee. And he has done a lot of research in the area of medical devices, biomedical engineering. Even he has collaborated with several industries in the design and fabrication of mechatronic systems for digital control of robotic platforms. And he's involved in design and implementation of miniaturized digital hardware for digital control over multi-linked flexible robots. He's been involved in a FP7 European projects as well, and he's got a great legacy of being invited in several occasions. One of them, he has been invited as a keynote speaker in the scientific session at the annual Congress in EAES Congress in Amsterdam in 2016. So I'll open the floor for Dr. Luigi to present his discussion today. So thank you so much for agreeing to present today. So I'll be very happy if you can start. I'll mute myself.
Yeah, thank you. So, okay, I'm going to share my screen. Can you see it? Can you see my screen?
Not yet. I'm still waiting for it to arrive. No, not yet. Yeah, now it started. Yes, here it is.
So thank you so much for a kind introduction, for the invitation. It's a pleasure for me to give a talk. Thank you to York University for hosting these meetings. And today I'm going to talk about flexible endoscopy and the important role of AI in this content. So I'm part of School of Medicine, but I have a technical background. I'm a roboticist. I've been working on the technical aspect before for industrial application in general, and then in the last 13, 40 years on medical devices. Now, flexible endoscopy is quite an important aspect of medical application. And particularly in this frame, I show where flexible endoscopy is used. And basically, as you can see for the anatomy, is where a surgical site cannot be reached by rigid device. So he notes it's one of the surgical techniques where natural orifices are used to avoid abdominal incisions. Human organs are important in terms of shape. For example, the small intestine, which has a length of up to 7 meters and diameter of 2.5 centimeters, requires some technical challenges to be overcome, while the large bowel, with a length up to 1.5 meters and diameter that can go up to 8 centimeters, has a completely different technical challenges to be overcome. However, the design requirements are pretty much the same. So we want to deploy a camera inside the human body with illumination and insufflation together with a surgical instrument, can be a grasp, dissect, or snare, or others. And to do so, we need to design flexible actuation mechanism. And if you talk to a surgeon, they want to have a very stable and precise instrument to perform a surgical task. And then we have a control user interface where the user, in this case a clinician, can perform surgical operations. I focus my research on the large bowel, particularly on the screening and treatment of colorectal cancer. Here are some statistics, and as you can see in this graph, incidence of colorectal cancer is about 50%. So 2 million new cases in 21, and the mortality is about 1 million. Roughly about 40% more compared to 2012. And looking at the WHO statistic and forecast, we will have a similar trend for next 20 years. Early detection is crucial, and as you can see in this picture, mortality rate changes quite hugely if the cancer is detected stage 0, while it's very, very low if the cancer is detected at stage 4. There are several solutions to do screening of the large bowel. Some non-invasive, other invasive. However, the gold standard is colonoscopy, because it's the only procedure that can perform optical screening of the entire colonic wall, but can also remove polyps, because they may eventually become cancer. So this is an important aspect of colonoscopy. So even if you have a different non-invasive screening test, if you have any positive outcome, a colonoscopy is still required. Here in this slide, I compare on the right side the first colonoscope introduced by Olympus, able to perform the first electrosurgical polypectomy, so removal of polyps. This was 1969. And on the left, there is a modern colonoscope. So after about 60 years, the mechanical design is still the same, and it uses mechanical actuation by using cables. Now let's go in more details on the user interface. The control is applied by using an external handle with usually left hand, where you can control two wheels, and these two wheels can control 2 degrees of freedom at the distal bendable section. Then with the right hand, you control the rotation and you apply a pushing force, so 2 more degrees of freedom. And all the force applied against the instrument is applied against the colonic wall to have a passive bending of the insertion tube. So we don't have any control mechanism of the passive section. Now, the actuation is implemented by using an antagonist configuration for each degrees of freedom by using 2 cables. And the challenge is that when the section bends, cables are going to push against the external shaft, and this causes increasing of friction. So when the colonoscope is going deeper in the large bowel, the friction is going to become higher. And this causes higher torques on the external wheels with a lot of pain. And in up to 70% of cases, gastroenterology can suffer of musculoskeletal injuries. Now, the user interface here is completely controlled by the hand of the clinician. So you don't have any electronic interaction or interface between the human hand and the device. Now, a robotic system can be very helpful in this context. Now, I call them the robots because are robots that are able to be deployed inside the human body, and the design is very, very challenging. You have a lot of components, you have a camera, instrumentation, but then you have actuator system, sensory system, the design of the frame, imaging, navigation, electronics, controller. So it requires a multidisciplinary team to design such a complex component. And another challenge is that you cannot use off-the-shelf component because most of them need to be deployed inside the human body, where you have a very, very limited space. Nowadays, we have AI and deep learning. We have so many applications. However, with flexible endoscopy, they are limited to adenoma detection rate. So the surgeon is still controlling the device. When an abnormal lesion is appearing in the visual picture of the video flow, the system can provide an alert. But there is not much on autonomy and surgical task, and mainly because who is in control of the device is still the surgeon. And then having a robot can provide a huge amount of data for training purpose, but also to measure the performance. And data nowadays are very important to design AI systems. Now, the design of such devices should include the stakeholders to provide feedback and input. We have patients. It's a very painful and unpleasant procedure. So the patient wants to reduce pain, discomfort, and improve acceptability. We want clinicians to have a better ergonomics, better usability. So human factor is an important aspect. And then we need to also consider benefit for healthcare center, better outcome, quality, and lower cost. In a project I led, supported by EPSRC, I propose a system that can simplify colonoscopy in a way that can be moved from secondary care to primary care with a huge advantage in the early detection of any abnormality. Now, AI integrated with robotic system can have many advantages, also some challenges to be overcome. So a device, a robotics device can provide a better precision and control because this is what clinicians want to improve precision, controllability. You can perform remote control, teleoperation, telemedicine. You can enhance autonomy. You can have a multitask integration, augmented AI, and the real-time feedback. You can improve the training, collaboration, and you can provide data, which are very, very important. And nowadays are very, very limited with the current technology. AI can provide a huge amount of benefit for the clinical side. You can enhance the diagnostic, improving the accuracy. You can have real-time image analysis, which nowadays is available with several commercial products, personalized medicine, data-driven learning. However, what is important is cost for the device, for the technology should be cost-effective, and also this relates to having an accessible device or technology to all the clinical setting. But also it's important to pay attention on the clinical integration of this new technology. Now, if you look at a standard, a very high level architecture of a flexible endorobots, you have a locomotion system, surgical task, hardware, including sensor and actuators, and then you have a high definition camera vision system. And then the loop is performed by using a control by wire. So you have an external user console, and the clinician is able to control the locomotion and the performance of the device. In this way, you can reduce the force applied to the clinician hand, you can scale the motion, you can remove filter, and you can design a much better ergonomic device, and you can also provide data. So this is already a fact with keyhole surgery. We have Intuitive with the Da Vinci, but in the last couple of years, we have many other companies that are provided a similar solution for keyhole surgery. However, we have a very, very limited technology applied for flexible endoscopy. Now, if you have a control by wire, is here where imaging processing and AI can interfere with the control interface. And AI can be used to perform autonomous or semi-autonomous tasks together with imaging analysis. So the imaging analysis is crucial in this aspect since the robot needs to define the surrounding environment to perform tasks. Now, locomotion is very important in the design. Several aspects to be considered. You have limited space in the large bowel. The diameter of the colon ranges from 20 up to 80 millimeters. So very different from the small bowel where it's almost constant. The locomotion solution research centers have provided several, let's say, innovative solution to move the hardware or the device inside the colonic wall. You need to consider the weight of the device and the friction. And in a large bowel, you have a very, very low friction. And if you consider friction and weight, you can figure out that the traction for a small and light device is very, very low. So there are several different approaches that I'm going to explain in the next slides. And then the device, in most of the case, should be connected with an external device. Particularly in the case of colonoscopy, we need air insufflation to expand the colonic wall. Having an external power can facilitate the energy supply to the device, and then become even easier to deploy surgical instrument by using an external tether. However, if you have an external tether, you have a drag force, and you need to have enough locomotion force to overcome this drag. People have provided even wheels or legs, tried to hang or hook the colonic mucosa, but you need to be very careful because colonic perforation can be an issue. Then the colon is not flat, you have astrum fold, and then you want to deploy instrumentation inside the device. So different kind of approach, wireless, we have pill cam that can provide a video flow of the entire colony wall, however, doesn't have any surgical instrument, or there are people using different wireless locomotion to move the capsule inside the large bowel, or external, when you provide external power, external locomotion by having all the actuator outside the human body, or a combination between internal and onboard locomotion. Now, in this picture, I show several state-of-the-art design proposed by several research centers, are just a part, but there are many, many more. In the lower part of the slide, you can see the magnetic actuation, where has been research by the center in the UK, in Leeds, Professor Baldastri, but also Gastone Ciuti, Professor Ciuti in Scuola Sant'Anna. And then there are other approaches like the wheels using Sheppard alloy and many other innovative solutions. Soft material can be a very valuable consideration to be adopted in the large bowel. Here I show some of the solutions. Some are using a double balloon by using a spring to connect the two balloons. The advantage of having a soft pneumatic locomotion includes to have a distributed force around the colonic wall, and this reduces the pressure. The balloon can improve the stability for interventional capability, and you can also increase the locomotion traction, because the force applied against the colonic wall is not related to the weight of the device, but is related to the pressure of the balloon to expand and to provide anchorage against the colonic wall. And then using a polymer for a medical device can have a huge impact in the production cost. It can make the device eventually be single use. At the moment, the colonoscope is reusable, it's very expensive. The large healthcare centers, they have a reprocessing unit, but the small healthcare centers, they cannot afford it. So they need to send out the device for sterilization after each use, with a huge upfront cost, because they need to have several colonoscopes inside the center. Now, other advantages of using soft material is a low mechanical stiffness and compliant materials. Pneumatic or hydraulics is, from my perspective, a very valuable solution, because you don't suffer about cable friction like traditional cable actuation. You can reduce trauma and pain for the surgeon, and eventually you can avoid the sedation, which is used when you perform a colonoscopy. And again, low cost is another important aspect. But there are several limitations. Soft material provide a low output force and torque, which sometimes is required to perform a surgical task. The controllability is a problem because you have a stable solution, especially because the air is compressible and the soft material behave like a spring because it's a rubber material. There are different approaches to define the system or the inverse kinematic. Some researchers are using a model-based, other model-free, combined with a learning approach or an hybrid approach. It's very, very difficult to simulate because here we are talking about hyperelastic material, and then it's important to have sensor. And in the case of a flexible component, you're looking for flexible sensors. And then miniaturization is also an important aspect. When you reduce the size of the device and you're still using pneumatic or hydraulic actuation, the pressure is going to be very high. So it can be a problem to have high pressure inside the human body. I start to work on a double balloon locomotion solution. This video shows one of the preliminary experiments I performed some years ago. And here I'm trying to show that the balloon can provide an effective locomotion without damaging this plastic column phantom that is made by using a thin plastic layer. And here you can see that it's able to go around narrow corners because the two balloons are connected by using a flexible soft pneumatic actuator. You can see in this corner how the tip is able to bend and to follow the shape. And the approach is going to be similar to traditional colonoscopy. So the fourth phase of the device, of the procedure, the robot is focusing on reaching the distal part of the colon, the cecum. And after the cecum is reached, the surgeon or also robotics arm can just withdraw the device and can perform the inspection manually or by using an autonomous system. So I improve the device, I include all the functionality of a standard colonoscope, water jet, medical instrumentation, and here I'm using a standard 3 millimeter biopsy channel. Basically, any off-the-shelf instrumentation can be used for this device. Identification and the control can be performed by using a standard Xbox controller, by using two hands or one hand. Now, the first question I tried to address was about how much pressure the balloon is applying in the colonic wall. Because people may say, okay, the balloon can work in a plastic phantom, but is it going to produce pain to the patient? So I start to do experiments on identifying how much pressure is required to have enough traction. So if we look at this slide, I show all the pressure involved in the design. You have the air pressure of the balloon, you have the elastomer that is constraining the air inside the volume of the balloon, and then you have the column wall pressure that is providing an opposite direction against the pressure applied by the device. And then we have the soft pneumatic actuator force that is able to move the tip forward, but also the tether drag. So the diameter of the balloon is an important element, and here this balloon is able to adjust the external diameter up to 85 millimeters, that is above the average maximal diameter of a human colon. And then I perform experiment by using an instrument to measure how much traction the balloon can provide. And with a pressure of just 6.1 kilopascal, the balloon can provide more than 8 Newton of force. Considering that 7.6 kilopascal is a painless pressure during the traditional colonoscopy, I proved this experiment that the procedure with a balloon can be painless. The design of the soft magnetic actuator is very important because it can provide the force to move the device forward, the torso to pull the tether, and here the force is be above 10 Newton when it's passively obtained. So after finishing the extension and just releasing the air, and the active force can go up to 5 Newton. Now, how can you control the balloon if you cannot see inside the bowel? So I also implement a closed loop control where you can see just with the input provided by the Xbox controller, the balloon can start to inflate, and as soon as an external pressure is detected, it stops the insufflation after providing enough traction for the locomotion. So having a robot that can be completely controlled by an external user interface will allow the introduction of AI. To perform autonomous tasks, as I mentioned before, defining the surrounding environment is crucial. During colonoscopy, the clinician is looking at the video, is defining the center of the room, and is pushing the device forward. In case of colonoscopy performed by a robot, should be the vision system of the robot that has to identify the center of the lumen. We start to work on lumen detection in 2D, and we also know that one of the major limitations in AI supervised learning is the need of data annotation. So in this study, we use the mentor-student algorithm, where basically 40% of the labor were annotated by clinician, and then the rest, part of the rest of the frame were automatically annotated by the AI system. In this case, about 10%. And the system is still able to detect the lumen in real time. So here, real time is crucial since the control between the vision system and the locomotion solution has to be fast enough to avoid instability. So here you can see on the left picture how the system can work in synthetic data, so in a simulator. Then we train with a colon training fandom and still working very well. And on the last video on the right, even if the system has never seen before a real colonic environment, is still able to detect the center of the ruler. So the system works in real time, about 15 frames per second, can further be optimized if the language model is going to be translated in a more real-time usable language. And we have a very, very positive feedback because we show the technology to clinicians and they consider the real-time lumen detection close to excellent, providing a score of 4.35 up to a 5 score maximum. However, to the identification of the lumen got some challenges. In particular, if you have an occlusion and you detect just the lumen, the device can still touch the colonic wall. To do so, you need to define a 3D reconstruction of the colonic lumen, which is very, very challenging for several factors. And the main challenge is that a standard flexible colonoscope includes just one camera, and this is because of the limited space inside the large bowel. So stereo vision is well known. We use two eyes to have a 3D reconstruction of the environment. In the same way, 3D camera, they're using two cameras connect to each other and very close to each other. Now, in keyhole surgery, 3D vision is a state of the art for several reasons. The camera is deployed by using a straight shaft, as you can see in this picture. However, the design is quite bulky, big. You have a limited depth perception because the two cameras are very close to each other. And in surgery, the field of view is close to 60, 70 degrees, while in flexible endoscopy, you need up to 180 degrees of field of vision. So completely different lens for the camera. And then a stereo camera requires a higher bandwidth, increasing the rigidity of the cable. And in case of tethered device, this will increase the tether drag and then also higher cost because you need to deploy additional hardware, make the device bigger. So this solution works very well for pure surgery. However, for flexible endoscopy, it's difficult to be deployed. So what we have done, we implemented a monocular system and deep estimation by using deep learning. Now, the system built a 3D model by using just a 2D information from the camera. However, when you swap and you map 2D to 3D, you have the problem of ambiguity. So the approach we used was to use deep estimation on video sequences. So the standard 3D camera, they have two frames at the same time and the same plane, but our approach is to use two frames with different time by using a video sequence. Now, it's has been widely used for autonomous car, but you have a completely different challenges when you apply this technology for large power. You have low texture, you have specular lighting, occlusion, surface deformation is another big challenge, and then you have a lot of lens distortion because you have a large field of view. And since we perform all the experiment by using a plastic funnel, we have additional challenges. So there is not much texture, specular lighting, very high occlusion. You don't have much surface deformation, but you still have less distortion. So in this video, you see how the system, again in real time, can detect the two dot point, which is closer and the distal part of the lumen, and then you have the green part that is a real-time trajectory plan that is obtained by having a slice of the 3D environment and by calculating the center of the slide for each step. So on the center part, you can see the deep estimation, on the right part, the deeper part of the lumen. We also implement AI for lesion detection, again by using the mentor-student approach. And here again, we can recognize in real-time lesion. Now, just to conclude my presentation, the integration of AI and endorobotics offer significant advantages for flexible endoscopy. However, to fully realize their potential, challenges must be considered to assure cost-effective and accessible integration into existing healthcare system. So thank you for listening. I would like to acknowledge all my collaborators, postdoc, and my team, together with several centers, School of Medicine and University of Dundee, and my funding body, UPSRC, Scottish Enterprise. And here are some references. So happy to answer any question you may have. Thank you.
Thank you so much. It was wonderful talk. I just wanted to ask if anybody has any questions to ask from Professor Luigi. You can raise your hands on the Zoom call. Okay, maybe before other people prepare, maybe I can ask a few questions. In the endoscope which you have showed on the slides, yeah. Okay, Oliver, I'll come back to you. In the slides when you talked about the balloon going in sequence, will the balloon actually has faced any trouble using bursting? Like, has it popped while it is moving inside the colon?
At the beginning, the main challenge was to design the balloon, to be
Oh,
honest.
yeah.
And the challenge was mainly about the shape of the balloon. The first attempt, the balloon was not inflating in the right way. So it was inflating more on one side rather than the other side. This was the first challenge. And the second challenge was about the internal pressure. Now, if the pressure to inflate the balloon is very, very high, it's difficult to perceive any external contact with the colonic wall. Basically, because the ratio between internal pressure and the external interactive pressure is very important. But after, let's say, several iterations, I consider the balloon quite consolidated as a design. But the main challenge that I faced in the design was basically the design of the 3 degrees of freedom soft thematic actuator. And basically, because anyone that is working on soft robotics knows that most, probably all the soft actuators are not stable.
Yeah.
So if you provide an unstable system to hold the camera is shaking and you don't have a clear picture. I cannot share now because some of the new technology I'm working on has not been published yet, but the latest version of the soft-thematic actuator is very, very stable. So you can control the camera by having a steady control, but you can also perform fast movement. So you can combine precise control and fast movement that are essential. Inchworm locomotion can be quite slow because every time you need to do a step to move it forward. So the speed and the controllability, the mechanical bandwidth of the connection between two balloons is crucial to have an effective and fast locomotion solution. So I performed some experiment in a plastic funnel, and the average time to reach the distant part of the column is between 5 to 6 minutes, sometimes even less. So it's very similar to other technology available on the market. But yes, the main challenge was to design the 3 degrees of freedom soft thematic actuator.
And the 3 degrees of freedom means like it's just moving back and forth. And is it like yaw and pitch as well?
So you have rotation, roll and pitch, but you also have extension.
Yeah.
So what the robot is doing is to inflate the rear balloon, to rotate and extend the top, the SPA, automatic actuator, and when you reach the end of the extension, you inflate the front balloon. Then you deflate it, you contract, and you inflate. So you have a step by step. So at the beginning was, let's say, not very fast, but now it's quite effective from the speed point of view.
That's very nice. Maybe Oliver, you can ask your question before I even ask more questions.
Hi, yeah. Thank you for the talk. It was very interesting. Can you hear me okay?
Yes, I can hear very well.
Yeah, I was just gonna say, what are the materials challenges from a physics perspective of, okay, so how do you go about the material selection for these endo robotics to make sure it has that flexibility and also is safe for being inside the human body?
So EcoFlex 0030 is the one I'm using. And who is working with soft robotics is for sure familiar with EcoFlex. The 0030 is a good compromise because it can provide an extension up to 900%. So it's very, very flexible. Even the curing time is quite slow, at least 2 hours, as far as I remember. So you have time to put in your mold and to degas it and eventually to provide a high quality part. Yeah, and this one is also biocompatible because EcoFlex is used for making masks. Now we are close to Halloween, so Ecoflex is quite a useful material to do masks. You can find guidelines on how to build a balloon on my publication on scientific report. And then in this publication, I show a preliminary design of the soft pneumatic actuator. To be honest, was not very stable since I was using the standard approach. So the standard approach to do a SPA is by using 3 different chambers and then a thread around to avoid the lateral expansion. I think most of the soft pneumatic actuators are using this kind of solution. But there are challenges. And the limitation of this approach, it is a standard one, is basically you need an internal cavity for the passage of cables. Now, if you're using 3 external chambers and an empty cavity, when you apply pressure against external chambers, they squeeze the central cavity. So you have friction, and this is a big challenge for the controllability point of view.
Okay, great. So there's one question on the chat. So William Burbridge is asking that it was mentioned that the soft robotics endoscope allows for single use due to its low cost. How would you expect the overall procedure cost to compare to traditional endoscopy? And what could help to further drive the cost reductions?
Yes. Okay, so I've been doing a lot of work because I'm working to commercialize outcome of my research with a spin-out from the University of Dundee. So you ask a very important question. To answer your question, usually an health economic is important. So it's not just the cost of the device, but all the benefit that the device can introduce in its use. And as I show in one of the first slides, basically the main stakeholder should be considered. Now, just the production cost can be very, very low. It's a polymer. At the moment, I'm using 3D printer and the mold process, just because it's very fast to go through an iterative process. But polymer can be done by using injection molder, and injection molder eventually can cost fraction. The cost can be expensive, several thousand, 10 or 20, but eventually you just use a material and it's very, very low cost. Then you have the cost of the camera. Again, for mass production, become very, very low. So production cost, from my estimation, can be about £100, apart the external console. And then you have many benefits. You don't need a reprocessing unit. I'm giving you a whole picture about cost because it's not just a device. You don't need a reprocessing unit if you make it single use. You avoid disease cross-contamination, which is now a well-known problem in flexible endoscopy. And then you have other benefit for the clinical point of view. Ergonomics is one of the most important, since people can take time off if they have musculoskeletal injuries and so on. If you support the workforce, you can detect the cancer at early stage. So the cost for the healthcare, if cancer is a stage 0, is very, very low. If cancer is stage 4, is much, much higher. So it's quite a complex system to be described, to identify how much you can save. But from my estimation, in total, you can save up to 45% of the total cost. So you can have 50% of saving, roughly.
That's very nice. That's a lot of saving if that can happen.
Yeah, definitely. Just in the UK, we have about 1 million colonoscopy every year in the NHS. And for the NHS, average price is £640, the average cost of colonoscopy. Plus, you have private centers, so it's quite a huge amount of saving every year.
So would that cost include the reprocessing cost, like once it has to autoclave and everything?
This is a reimbursement cost provided to NHS. So the NHS gets between 600, 700 pounds, depending on the complexity of colonoscopy, based on public available data. But the reprocessing unit is difficult to identify exactly how much is the cost for the reprocessing unit, because the reprocessing unit is not just focused on colonoscopy, any flexible endoscope, so even upper GI. So identify exactly the cost for reprocessing a single colonoscope is quite challenging.
Okay. And anybody else with more questions? You're free to put it on the chat if you're a bit shy to come forward. Okay, maybe I have one last question. You mentioned about the AI algorithm which was running to look at the lumen center. So maybe I missed, what was the labeled data in this case? Like, how was the model trained?
So basically, we were manually annotating the contour of the lumen. And based on this information, the system, because the lumen detection, the 2D, is supervised by using a mentor-teacher approach. So we were selecting the contour and the system was providing with annotated frames, and then was running in real time. So it was very, very fast. We were using a high-performance workstation to do it in real time.
And when it runs, then suppose the robot has to now look at an unlabeled data. That means it has to find the lumen. So then it will automatically pitch itself and move in the direction where the lumen is.
Correct. You have a delta XY because it's 2D between the center of the camera and the center of the lumen. And then you apply a visual servoing controller, let's say, to move the camera in the center of the lumen. The challenge is to make this movement stable. So this is why you need to have a fast imaging processing server system, but also a stable control device, because if the device is not stable, you start to shake, and then the quality of the video decreases, and it's difficult to keep the identification of the lumen in real time.
Thank you. Thank you so much. That's quite interesting to know that. I'll ask if anybody else is having any more questions. That would be so nice. We'll have a good utilization of this last few minutes before we end this seminar. Okay. Maybe there's none at the moment. So I thank you so much, Professor Luigi. It was amazing having your talk, and we learned a lot. So thank you so much.
Thank
Thanks.
you so much for the invitation. Thank you to the audience.
Thank you. Thank you so much for everyone who managed to come today.
Thank you.
Thank you.
Bye-bye.
Thank you so much. Thank you. It's very interesting. Thank you.
Thank you.
Thank
Bye-bye.
you.